xin trình bày một cái bệnh.
Thank you very much for this invitation. We perform this presentation because that is so very important in this moment in cancer patient treated the secondary myocardial toxicity after cancer therapy for us in Don Hoy Hospital. An overall increase in survival cancer patient is so important has been to do the use of chemotherapy or maybe combined treatment, because it's not only chemotherapy the treatment we perform in this patient, maybe combination between chemotherapy and radiotherapy too. And in this moment, this radiation induced heart diseases, and these developed are nonetheless associated with emergent concern to other drugs, the induced cardiotoxicity. For us, so many clinical trials demonstrate cardiotoxicity in other drugs. For example, anthracycline, anthraquinolone, antimetabolite, alkylating agent. But now, in this moment, we have a new group of drugs for treatment in cancer patients, for example, proteasome inhibitors or monoclonal antibody, tyrosine kinase inhibitor, inductor of cell differentiation, and histone deacetylase inhibitor too, and they are the principal reason in consideration for target treatment that develop cardiotoxicity too, relating to treatment for chemotherapy. Knowledge of this side effect and the main risk factor associated with cardiotoxicity in cancer patients is essential for adequate monitoring and early treatment such as even on this patient. Is concerned to reflect because it's not all time we have this position for employ as treatment in this cancer patient drugs that have preventing, because for example, these drugs, doxorubicin pegylate, is for preventing this cardiotoxicity. And at the same time, when we use nanomedicine, because nanotechnology for protection in this type of patient is so very important. How is the role of oncology in cardiotoxicity? The principal role is evaluate the clinical in patient. That involves the symptom for assist symptom, electrocardiogram, or any other study for classify after this evaluation, this clinical evaluation, the patient. Analyze the chemotherapy schedule because the selection of the drugs all time must be to less toxicity for improve the best treatment, and the management of primary prevention for identification the high risk of population. In this way, we select all time for preventing dexamethasone as so very common drugs for preventing in cardiotoxicity. When the patient has the high risk for present-day ventricular dysfunction or QT elongation, is necessary monitoring patient, and when appear any trouble, is necessary early treatment for this dysfunction, hypertension, coronary artery diseases, or other. We have four levels for demonstrate diagnosis in cardiotoxicity. But the first level for us, and the most important level, is clinical level, because all time in clinical guide, in NCCN clinical guide, we have for clinical diagnosis, follow the different steps. The first step is evaluate the historic and physical examination for assist the symptom or to obtain any diagnosis for heart failure in this patient, assist patient to ability to perform routine. Maybe the patient has the possibility to show us in this evaluation the very good control for this activity, maybe no. Maybe the patient need to assist all time for us. Evaluate for presence of the heart failure risk factor, such as arterial hypertension, diabetes mellitus, dyslipidemia, age higher to 65 years, or history of cardiovascular comorbidity, review the other risk factor because maybe the patient has the smoking, alcohol, obesity, or other. Review the oncology history because we have the possibility to send the patient to cardiology and explain how is the treatment developed in this patient. Maybe the treatment is focusing in anthracycline, or maybe any combination, and this combination includes radiotherapy or target treatment too. On the other hand, as clinical, it's necessary to review any electrolyte disorder, because hypomagnesemia or hypercalcemia is not good for control in cardiotoxicity with this patient. All time I think the cardiotoxicity is the same as iceberg, and we don't have capacity all time for see what is the biggest magnitude of this problem. Maybe you have capacity for obtain only information for symptomatic left ventricular diffusion, but in depth, cardiotoxicity have so many other troubles. Many other troubles relating to chemotherapy, radiotherapy, biology therapy, target therapy, or cardiac risk factor, because the patient, when you study the patient, appear this trouble. If you don't study the patient, you see only the iceberg higher to the sea level. On the other hand, the second level for cardiotoxicity diagnosis is electrical diagnosis. We use all the time the electrocardiograms. It's useful in cancer treatment for demonstrate arrhythmia, QT prolongation, or maybe other troubles in the patient. Today, we have also increased development day by day in imaging, in cardiac or maybe other diseases. In cancer patients, it's so useful to perform echocardiogram by Doppler or not Doppler, but not all time we obtain the reality in this patient, because maybe echocardiogram say us ejection fraction is normal, but this technician is our support for develop in this moment global longitudinal strain, because global longitudinal strain many way is a way for demonstrate early heart failure in our patient. Other imaging diagnosis is using for nuclear medicine, for example, SPECT-CT, MRI. MRI shows us any trouble as a structural damage in cardiotoxicity patient, but SPECT and SPECT-CT show us not only damage in a structure, no, functional damage too, because it's necessary to perform this study for demonstrate the function of the cardiovascular system is not good when cardiotoxicity appear. It's not only useful for demonstrate diagnosis, it's useful for following when you perform any treatment in cardiotoxicity patient. This patient, for example, has heart failure, refractory heart failure, and after treatment with implanted stem cell, we follow this patient for develop the new cells in cardiac with SPECT-CT. That is other use in our third level for cardiotoxicity diagnosis. In the fourth level, I want to say congratulations ASEAN region, because in ASEAN region start this fourth level diagnosis by endomyocardial biopsy here in Japan in 1962, beginning this way. And that is useful for demonstrate so many diseases. More than 26 diseases were studied by endomyocardial biopsy. But for us, as oncology, for demonstrate cardiotoxicity by doxorubicin or other anthracycline, cardiotoxicity by irradiation lesion, or maybe primary tumor in cardiac, maybe secondary tumor in cardiac. Fortunately, we have in this moment the possibility to show us our work in Don Hoy Hospital for demonstrate this possibility in our patient. The finding, when you have the pathophysiology in cardiotoxicity, is as a histological study, the rupture or loss of cardiomyofibrils, mitochondrial edema, and structural alteration in cellular endoplasmic reticulum, producing as myocyte evacuation and subsequent loss of functionality. That depends on the doses, because when you employ middle or low doses in anthracycline, for example, the damage is partial. But when we employ When we use high doses, the damage is total, leading to myocytic necrosis and its loss. We have different play in the world. For example, Cuba, Spain, Argentina, different centers have the cardio-oncology unite. And that is our intention in this moment of our work here in Don Jorge Hospital, Friendship Hospital, because it's necessary for us to create a new cardio-oncology unit for protect all patients that arrive at our center treated with any chemotherapy or maybe radiation in chest or maybe any schedule, the combination of these possibilities to cancer treatment. What does a cardio-oncology unit offer to the patient? As Dr. Peter said before, we maybe promote effective communication and decision-making channel among professionals involved in cancer treatment, develop protocol for prevention, diagnosis, and early treatment, as well as follow-ups, cardiovascular complications, stratify the cardiovascular risk for the oncohematological patient, facilitate oncological treatment, and avoid interruption in the administration of anti-tumor treatment, promote training program as professionals involved in the care of patients with cancer and cardiovascular diseases, and create register and evaluate the results in health and quality of care or coordinate research protocol. For us, that is so very important and necessary. We invite both department, both teams for working together, and we prefer that because start to work as cardio-oncology so an understanding between all equipment, develop individual relationship and understand the needs, because that is a need for the patient. Work as a team and understand how you can offer, how you can deliver in this cancer patient. All time we base our work in guideline and create this platform in our hospital. We presented our direction board this project. This project is for a study cancer patient who come or arrive at our department, oncology department, with potential risks of cardiotoxicity due for cancer treatment receive, to stratify according to the level of the risk, administrate the precise treatment, and carry out follow-up because it's necessary to devise the activity. This support have in this moment this clinical trial registered, and we start to include the patient in this protocol. For ethical, we think presenting our department our principal logotype as a cardio-oncology unit. We select this ring, blue ring, and including inside the ring two logotypes. One logotype is our National Oncology and Radiobiology Institute in Havana. The other is the logotype of National Cardiovascular and Cardiosurgery Institute in Havana. And close the ring, the logotype of our hospital here in Don Jorge in Vietnam. This is the logotype of our hospital here. This is our house in this moment. So this is our tool for include patient. We review the general information about the patient. We perform the disease history of ability in this patient, physical examination, the subclinical examination in all patients that arrive in our department, performed by the cardiology, the score according to stratify of the different findings in this patient, and we receive in our department this summary. This summary has diagnosis, prescription, and comments coming from cardiology, and we follow this patient because it's necessary to supervise the treatment for reduced cardiotoxicity and following to evaluate what is the evaluation final in this patient. I want to show you the 3 first case evaluate in our department with our Dr. Peter, our cardiology. The first, all patients have ACC, hepatocellular carcinoma. All are men, and all patients receive as treatment transarterial chemoembolization. Okay, different course, different cumulative doses of doxorubicin that's in play in this one. The first is patient receives as cumulative doses 250 milligrams. They have history to palpitation, and electrocardiogram show us sinus rhythms and cardiotoxicity diagnosis. The finding is left atrium enlarged. Look at that. 40.4 millimeters. Our area is 12 square centimeters. Biplane diastolic volume is 64.4, and the index is 42 millimeters square meter. Global strain, global longitudinal strain is normal, and recommendation is close monitoring this patient by Holter electrocardiogram to high risk for future atrial arrest. The second case presented in this moment, yes, please. We want to present this case because this case is so very interesting. We find in the interior of the right atrium tumor. Okay, this tumor proceeding for inferior vein can, proceeding for hepatic vein too, and in our imaging, look at that. We have this mass and this mass. I don't know why it doesn't. This mass is 2 centimeters in interior of the right atrium. The third space, that's the high level of cumulative doses of doxorubicin, shows 450 milligrams, and have the moderate mitral regurgitation because has the prolaxis. Look, the prolaxis here, okay? And Pisa rate is 0.6 centimeter, ERO in 0.22 square centimeter. Volume is 21. Grade 2 diastolic dysfunction, symptom biplane for ejection fraction is normal, and low probability to pulmonary hypertension. Our recommendation in this patient for demonstrate heart failure or no heart failure is perform biomarker as NT-proBNP. On the other hand, in this moment, for the first time in the world, celebrate in Brazil in September the International Victory Symposium, and in this symposium, the president of Brazilian Society of Cardiology announced the cardio-oncology begin as a specialty. It is the first country in the world start cardio-oncology as a specialty. For the first time, this is the reason because our specialty combined with the cardiology start in this moment to training for 4 years for obtain and the final cardio-oncology specialty. That is our reason for perform this presentation, and I hope in the future continues to working with this patient in our hospital and show us in other moments how is our result. Thank you very much for this.